Have you ever wondered why nearly every medicine cabinet in America has a little tube of triple antibiotic? And I'm sure everybody's been there. They've heard their patients say, "Oh, I was putting triple antibiotic ointment on it." It's definitely macerated from that, and why it becomes so common, like mainstream, like first choice for people when they don't want to go to the doctor. Who invented it, why there are 3 antibiotics instead of 1, right? And how did we get from it becoming, like, very trusted, okay, to everybody just using it? And the thing that I try to make my patients understand, everyday wounds are completely different from diabetic ulcers. Diabetic ulcers are in their own category. They're not an everyday wound. And that's the problem that I've noticed a lot of people why they try to treat diabetic ulcers the same way as everyday wounds. They're not. They're a diabetic ulcer. There's a reason why there's a classification system. There's a reason why it has its own diagnosis and names because it acts quite differently. So, who invented it? The triple antibiotic ointment. So there's a great misunderstanding. Like I said, triple antibiotic ointment was designed for minor, uncomplicated skin injuries, like little scrapes. Okay. A diabetic ulcer, a diabetic foot ulcer is completely different. It is often influenced by neuropathy, as we know, diabetic foot ulcers, we have reduced blood flow. That's why we call it neuroischemic. There's repetitive pressure. That's why offloading is key. And their immune system is altered. The wound is usually in this chronic state of inflammation. It doesn't get past go on the Monopoly game board, right? And sometimes there's deep infection and biofilm, okay? And these problems cannot be addressed by triple antibiotic ointment, okay? The triple antibiotic ointment rarely can solve this on its own. So while the tube has earned its place in the first aid, you know, go box, right? A lot of triple antibiotic ointments are in first aid kits, right? It was never meant to replace a comprehensive diabetic foot ulcer treatments. So I hope people can understand that. Some people are under this misconception. It healed my paper cut on my hand, right? Why wouldn't it heal my diabetic foot ulcer? Well, it's completely different, right? These are two different playgrounds. Everyday wounds is, uncomplicated everyday wound is simple, right? Diabetic foot ulcer, aka a neuroischemic ulcer, you're playing in the big leagues, and triple antibiotic cannot help with that. I've never seen it do that. Okay, so let's talk about the history. Okay, everything changed in the 1920s when Alexander Fleming noticed that mold contaminating one of his laboratory dishes was actually killing the bacteria. And that discovery led to penicillin, as what we know, which became widely used during World War II. And for the first time in history, doctors had this joke that they can use that reliably kill dangerous bacteria, and the impact was extraordinary. So soldiers survived wounds that previously would have been fatal. Operations became safer, life expectancy improved, but there was a problem. Penicillin was designed to circulate through the bloodstream. And what if somebody had a simple scrape on their knee or a cut on their finger? So researchers wanted something that people can apply directly on their skin before antibiotics, like something that they can use for a simple scratch, right? Because a lot of people did die from simple infected splinters, shaving cuts, burns, even childbirth, and tiny puncture wounds. And during World War II, infection killed thousands. And then antibiotics came and penicillin changed medicine forever. But doctors wanted something that they can, for skin wounds, pretty much, something that people could simply rub on. And researchers began combining antibiotics that attack the bacteria in different ways. And that's how we came to this famous combination of bacitracin, neomycin, and polymyxin B. Okay, these are three different antibiotics. They have 3 different mechanisms that we're gonna go into, and they are put in 1, 2, 3, 3 in 1. I guess that's where they got the term, right? 3 in 1. So why these 3 antibiotics? Why not just one of them, right? Because bacteria aren't all the same, and we don't everybody doesn't have a wound culture that they could just do at home, right? So imagine criminals wearing armor. And some hide underground, some attack in groups, some attack in fortresses. We already know there are different types of antibacteria. So let's talk about the first ingredient, bacitracin. So bacitracin pretty much is the wall destroyer. So imagine bacteria trying to build a brick house and the brick wall protects them, and without it, they explode. So bacitracin blocks the bacterial cell wall construction. Without a wall, water rushes in, pressure builds, and bacteria can burst. So it works really well. Bacitracin works really well with gram-positive organisms like Staphylococcus aureus, Staphylococcus species in general, and Streptococcus. And these are commonly infected like cuts, everyday cuts, right? So bacitracin was discovered in the 1940s from a bacteria that was isolated from a young girl's wound. The organism was named was the organism, like the bacteria, was Bacillus lynchiformis, and that produced a substance that killed other certain bacteria. So researchers named this antibiotic bacitracin using part of the girl's name Tracy. Her name is Margaret Tracy, which is cool, right? At least she got some notoriety. And bacitracin mainly targets, like I said, gram-positive bacteria, common with like Staphylococcus, Streptococcus, right? Preventing the bacteria from building a functional cell wall. Okay, without a strong wall, the bacteria can't survive. Now, next second ingredient is the neomycin. Neomycin is the protein killer. So every cell has its factories, and these factories build proteins. Proteins keep the bacteria alive. So neomycin sneaks in, it jams the machinery. Instead of making useful proteins, the bacteria begins making like garbage. It doesn't know what it's doing and eventually dies. And that's quite powerful. So neomycin was discovered from soil-dwelling Streptomyces species, and the soil has been one of nature's richest sources of antibiotics, if you haven't noticed, because the microorganisms constantly compete with one another. So neomycin belongs to the aminoglycol family, and instead of attacking the bacterial wall, it attacks the ribosome, the cell's protein making machinery. And this causes the bacteria to manufacture defective proteins and eventually leads to cell death. Next is the third and final ingredient. Well, actually, there is another ingredient, petroleum, right? But we'll get into that. Polymyxin B, the membrane destroyer. So think of bacteria as balloons, and the membrane is what keeps everything inside. Polymyxin punctures holes into the membrane, and the bacteria leaks. Okay, and it essentially affects mostly many gram-negative bacteria. So together, those three antibiotics, right, can in combination attack gram-negative, gram-positive, and then the proteins to make it dysfunctional. Okay, and so I forgot about the little history of polymyxin B, but polymyxin B was isolated yet again from another soil bacterium. I am not going to be able to pronounce that word. And scientists discovered that it was essentially effective against gram-negative bacteria, which were protected by an outer layer that makes them more difficult for many antibiotics to penetrate. So polymyxin B is like a detergent, disrupting the membrane until the bacteria leaks and dies. So let's go over again. So every tube of triple antibiotic has bacitracin, which disrupts the cell walls, neomycin, which disrupts the protein production, and polymyxin B that damages the outer membrane of the susceptible gram-negative bacteria. Now, why is it mostly a ointment, right, instead of a cream? So that is a kind of deliberate thing. So a lot of manufacturers choose to use petroleum-based ointment, okay? Why is that? Because petroleum forms a protective barrier. And as we all know, when we have patients that use triple antibiotics, they usually come in with their wound macerated, with the whiteness over saturated with moisture, right? And it's because it's mostly petroleum based. It quickly reduces water loss from the skin and protects the minor wounds from external contamination and keeps superficial wounds from drying out, right? It's just a paradox because some patients or people are patients patients, people, anybody. Some people just wanna air out their wounds, some people wanna slather it with triple antibiotic. It depends, you know? But either way, I just try to make people and patients understand that diabetic ulcers are the big leaks. So it's not meant for triple antibiotic ointment, okay? Definitely just go into you see your doctor right away, like ASAP, or go to the ER so that we can get this treated properly before it gets to amputation risk level, okay? And for chronic diabetic foot ulcers, like I said, we're in the big leagues when it comes to wounds with that. Prolonged occlusion, which is caused by petroleum, okay, based ointments, right? Prolonged occlusion can contribute to excessive moisture and maceration, right? And yes, there is a balance when it comes to wound healing, but as we know, a lot of patients do slather it on, do put it on a lot, things like that, okay? So why do a lot of diabetics reach first for it? Okay, because this part is quite understandable. We do hear that a lot of patients say that ulcer starts first as a blister, okay? They get scared, they don't wanna bother anybody, and a side note, you're never a bother, please come in immediately. Like I said, I give my patients my cell phone number, text me immediately, okay? Even if I have to come to your house and you're like, "I don't have transportation," I rather that than you saying you can't come in a few days, things like that. I rather time waits for nobody, right? That's what they say. Neither does a diabetic foot ulcer, right? And yes, the wound doesn't hurt because of neuropathy. The sensation is taken away. And the people will think, okay, I'll just put some triple antibiotic ointment on it. And you're not trying to ignore the problem. You're actually trying to solve it. But unfortunately, like I said, diabetic ulcers are the big leads, okay? They're not an everyday wound. So, why are diabetic foot ulcers completely different, right? Most diabetic ulcers are neuroischemic ulcers, right? Paper cuts are paper cuts, but a diabetic ulcer is not a everyday ulcer. Like I keep on saying, the biology is completely different. Several major issues do occur a lot with diabetic foot ulcers. The neuropathy, the patient cannot feel, pressure continues, and the wound can get larger. Poor circulation, as we know, a lot of our patients are have micro or macro vascular complications when it comes to diabetes. We went through a whole episode about how it affects your blood. And we know that our blood carries the oxygen, our blood carries our immune cells, our blood carries the nutrients, and without blood, healing slows down dramatically. That's why we love vascular. I love you, vascular. And what repetitive trauma, that's why offloading is key. So every step can crush tiny blood vessels. The wound can get bigger. And then our high glucose levels, so the hyperglycemia, elevated glucose impairs the white blood cell function, increases inflammation, and slows tissue repair. And as we know, diabetes does cause the immune system to be dysfunctional as well, okay? And the body's ability to fight infection is greatly impaired, so triple antibiotic cannot correct these problems. Now, let's get back to the one of the biggest factors is biofilm, okay? So we already know biofilm is a slimy communicative layer that's created by bacteria. It's like a medieval castle for them, okay? And antibiotics struggle to penetrate it. That's why usually we have to debride these ulcers one way or another. There are different types of debridements, as we know, okay? There's autolytic, enzymatic, there's sharp, okay? There's mechanical. There's all different ways, right? But we usually do have to remove that dead tissue and biofilm, okay? And never do it by your patients. Don't ever debride anything on your wound at home. I've noticed some patients have tried to do that and it makes it worse and it usually sends the patient to the hospital where they need surgical intervention. So I would rather you not do that. Don't ever do that. I always say, don't ever self treat. Don't ever self treat. I mean, sometimes I've seen very rare occasions where I'm happy that they did this and I was like, oh, this helped a little bit. But no, don't ever self-treat. Contact your doctor immediately, like, call them immediately. Tell them exactly what's going on, okay? Or go to if they cannot see you, go to urgent care or the ER so that they can actually see it, an actual healthcare professional can see it and tell you what to do, but definitely call your doctor, okay? Now, why does it cause a lot of maceration, okay? That's one of the biggest problems with petroleum-based ointments is maceration, okay? Like I said, imagine we all seen our hands. I remember when I was little, I loved to swim. Your hands end up pruny and white, right? Wrinkled and fragile. That's maceration. And when excessive ointment, like triple antibiotic ointment, is placed on a draining diabetic ulcer and then covered with an occlusive dressing, right? Our patients like put band-aids on it. The surrounding skin gets overly wet and the edges become weaker, and that can make the wound much significantly bigger, okay? Making it easier for the wound to enlarge and harder for healthy tissue to advance to cross over the wound bed and close. So, I hope people understand that because I understand the goal of balanced moisture environment, but I would just leave it to the professionals. Now, another thing that happens with triple antibiotic ointment that I feel like a lot of my patients did not understand, that a lot of people do get contact dermatitis from triple antibiotic ointments, and that's because of a particular ingredient. It's neomycin, so the skin can get red, itchy, swollen, weeping, and blistered like, okay? And that is important to know. So, what about triple antibiotic is not good for a diabetic foot ulcer? So, first of all, it only works on the surface, okay? That's what it was made for. It's superficial, uncomplicated little skin injuries, okay? Diabetic foot ulcer, a neuroschemic ulcer. It has dead tissue, it has biofilm, most likely has tunneling, undermining, infection extending deeper into the tissue or bone, okay? An ointment cannot do that. It cannot reach that deep. So imagine painting the roof of a house that's on fire and the fire's in the basement. That's pretty much what we're dealing with, okay? The roof may look different, but the fire keeps on going. Now, another thing triple antibiotic ointment does, it doesn't do anything for ischemia, poor circulation, okay? So our neuroischemic ulcers, they have reduced blood flow as we know. Triple antibiotic ointment doesn't improve circulation. So without adequate perfusion, even bacteria-free wounds cannot heal, okay? And that's why we love vascular. You are my son. Okay, also, it doesn't stop pressure, okay? A lot of our patients have neuropathy. They are able to walk on the wound because they do not have the warning system, the internal warning system anymore. So us as healthcare professionals, we have to become their external warning system, okay? And like I say, knowing pain, like somebody teaching you about pain compared to experiencing pain is quite different, okay? That's why people say experience is the best teacher because you could tell somebody that this is what's going to go on, right? But it's so different when they actually experience it. And you have to remember our patients who have neuropathy, they aren't experiencing the pain personally. So they can see the wound or they won't see the wound because it's at the bottom of their feet, right? And they're not experiencing the pain. The only reason I know that I've stepped on something is because I feel pain, okay? I'm not looking down at my feet all day. The only reason I know I stepped on something is because I have a ouch, right? And I step back. So always think about that, okay? Now, we already went about the contact dermatitis, okay? Another thing that triple antibiotic may do is it may alter the wound microbiome. So chronic wounds contain a complex mix of microorganisms. A lot of them are polymicrobial, okay? Not all bacteria are harmful, but yes, not all bacteria are equal as well. So applying a triple antibiotic ointment repeatedly can allow more resistant organisms to persist, can change the balance of organisms within that wound. Another thing it doesn't do is it doesn't correct the chronic inflammation. It actually might even prolong or even aid in that prolonged inflammatory phase that a lot of diabetic foot ulcers are stuck in. Okay. So we already know the normal healing phases of wound healing is hemostasis, inflammation, proliferation, which I love, and remodeling. And inflammatory stage, okay, the inflammatory stage, this is where the cells continue to release matrix metalloproteinases, the MMPs, and the inflammatory cytokines that degrade healthy tissue and growth factors. Triple antibiotic does not affect this phase in a good way, okay? It can actually prolong it, in my opinion, because it can cause that contact dermatitis. And it doesn't restore the impaired immune function. So we know that patients with diabetes with that sustained hyperglycemia, there's reduced neutrophil function, there's impaired phagocytosis, there's slower bacterial killing, there's delayed collagen formation, and there's impaired angiogenesis. So even if the bacteria is reduced on the surface, the underlying mechanism of the immune dysfunction still remains. And then another thing that triple antibiotic often does, it delays appropriate care. Okay. So a lot of people, when they put the ointment on, there's like, I'll give it a few more days, or it probably needs more ointment, or it probably is getting better. Meanwhile, the ulcer is just getting deeper, infection spreading, and ischemia worsening. So, like I said, you're in the big leagues now when you're in the diabetic, when you have a diabetic foot ulcer. That's why you have to have specialized care. It's not something to take lightly, okay? Don't think that when you have another thing I don't want patients to do is have fear-mongering. I don't want them to think that the moment they get a cut, that means it's the end. Oh, they have to cut it off. Absolutely, we do not know yet. And the fact of the matter is there are so many modalities to help heal wounds, to help save limbs, to help save toes. There's there's a lot that we can do, okay? So it's not limited like in the olden days, okay? And another thing is like we said, it doesn't help with surface, okay, too much, okay? With neurasthenic ulcers, a diabetic foot ulcer, they require far more than a triple antibiotic ointment application, okay? We need to assess the patient's blood flow. That's one of the biggest things, vascular assessment, offloading, debridement, most likely, managing edema, controlling the blood glucose, evaluating the deep tissue, selecting appropriate dressing. Why do you think there's so many wound dressings, right? And considering what vascular recommends, right? What do they recommend for this patient? So imagine a diabetic foot ulcer being like a house, right? And the house has four major problems. The electricity out, aka poor blood flow. The foundation is cracked, aka the neuropathy and the pressure. Mold is growing or biofilm is there, aka, and the kitchen is on fire, which is like the surface bacteria. Another thing that people need to understand is the difference between infection and colonization, okay? So not every wound that has bacteria is infected. Nearly all chronic wounds contain bacteria. And, colonization and infection is completely different, okay? Infection occurs when the bacteria invades the tissue and triggers damage and often producing signals like spreading, redness, warmth, swelling, and pain, pus, purulent drainage, foul odor, and systemic symptoms like fever. And this distinction matters because treating every colonized wound with antibiotics can contribute to the rise of antibiotic resistance and unnecessary reactions. Okay. So I want people to know that topical or triple antibiotic ointment does have its role in wound care, but it's definitely made for minor, superficial, uncomplicated skin injuries. Okay. However, when it comes to diabetic foot ulcers, I would not recommend it. Okay. Many diabetic foot ulcers have guidelines. Okay. First, definitely see your doctor. Never self treat. Okay. What matters the most when it comes to a diabetic foot ulcer is, first of all, seeing your doctor. Go to your podiatrist if you have a foot ulcer or any type of wound, scratch, or anything. Okay, we know offloading matters, reducing pressure with specialized footwear, cast, boots, or other devices. Vascular assessment is key. Okay, we have to know that the patient has enough blood flow. Without adequate blood flow, even the best dressings cannot overcome poor oxygen delivery. Debridement, if needed, there are, like I said, multiple different types of debridement, removing the dead tissue and disrupting the bacterial biofilm so that healthy tissue can grow. Advanced wound care, selecting the appropriate wound dressing and therapies that are needed that match the wound's actual needs. And the metabolic control, improving the blood glucose management to support immune function and tissue repair. So, in all, in closing, I guess, triple antibiotic is not a bad product, okay? It's helped millions of people. It has saved lives from when it first came out, okay? It helps with minor, uncomplicated skin cuts, okay? Little skin cuts. So it's earned its place in the first aid kits, okay? But when it comes to a diabetic foot ulcer, it is not an ordinary cut. Okay, diabetic foot ulcers, that's why they call it neuroischemic ulcers. They are driven by a combination of pressure, neuropathy, impaired circulation, inflammation, altered immunity, as well as sometimes deep infection. So no ointment can replace these factors that are trying to be addressed when it comes to a diabetic foot ulcer, okay? And the best wound care isn't what you put on the wound. It's understanding why the wound is there, okay? And treating the patient as a whole and as a whole person, okay? And not just a hole in the skin. So this has been Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.